Yeah, we carried out a real-world data study. This is a registry that we conducted over a number of years in 9 countries in the Asia Pacific. And these are registry data. So the patients are diagnosed, they receive treatment and follow-up according to local practices. So by doing so, we understood much better what the real-world practices are, as opposed to, for example, data from clinical trials, which are in a way artificial because they choose only a very special group of patients. This real-world data is very important because to do effective healthcare policies, we really need to know what's happening on the ground. And also for the pharmaceutical companies, they need to know why certain drugs are used and why other drugs are not used in order to come up with a strategy to develop treatment for the patients. So in our findings, we found that the Asia Pacific is very heterogeneous in terms of the treatment of patients with liver cancer. What we found that the presentation is actually quite different because in some countries, the patients are much older than the other countries. And this impacts on the way that the patients are treated. For example, patients in Japan has the highest average age at the time of diagnosis of 71.1 years. But in China, the age of diagnosis on the average is about 53.4 years, which is about a 20-year difference. So this affects the way the doctors treat the patients too, because of course, if the patient population is younger, more surgery will be done. And what we have found is that for stage, in the different countries, the therapies used are quite different. For example, in stage A, it is more uniform because most of the countries we use surgery. But once we go to stage B and stage C, then we see a lot of differences. And the differences are due to, of course, firstly, the patient profile, because if the patients are younger, then surgery is used more often. And secondly, also because of access to therapies. Some of these new therapies are not available in many countries or not evenly available in all the countries. So that's an important thing to understand. And if you look at the treatment outcomes for every single stage, for example, if I were to use stage A patients as an example, so most of these patients are treated with surgery across the Asia Pacific because they are very good stage patients. But their overall survival is very significantly different. For example, we see very good overall survival in Singapore and Hong Kong, less so in Korea and in China. And when we look at the reason why, we find that in many of the places, patients have more than one line of treatment. That means after they have surgery, after surgery, there'll be a second line treatment, a third line treatment, a fourth line treatment. The more lines of treatment they have, the longer the survival. So, for example, patients with stage A, for example, in Singapore, after surgery, another 71.4% of them will receive additional lines of therapy, more than 2 lines of therapy. Whereas the number of patients who receive more than 2 lines of therapies after surgical resection is only 21.8% in Japan. So obviously, in the real world, patients are receiving multiple lines. Of course, if they receive multiple lines, they tend to live much longer. For example, if there's a recurrence, then they can go for radiofrequency ablation. And if there's more recurrence, then they can use other modalities like Y90 and maybe also immunotherapy. So many lines of treatment actually is associated with much longer survival in a very significant manner. Yeah, in fact, the country with the most developed screening program is Japan. Japan is by far the country with the most developed screening program. So it's not Singapore. So in Japan, a large proportion of the patients are diagnosed early, right? But I think the thing that is different about Singapore is that we tend to have multidisciplinary care, which means the patients are looked after by different specialties so that there are multiple lines of treatment. And that is where I think it is different in Singapore. And the multiple lines of treatment really translates. Our data is very clear. The more lines of treatment the patient receives, the longer the survival. Because, for example, for a natural history of a patient with early liver cancer, the first line of treatment may be surgery. Maybe 2 years later, there is a recurrence. And if he receives a second line now, either surgery or RFA, then he'll live longer. And if in another year's time he recurs, maybe multiple recurrence, then he uses Y90 and so on and so forth. So the multiple lines of treatment is actually very important on top of a screening program. Screening program picks them up early, but after they're picked up, how long they live is also dependent on how many lines of treatments are used for these patients. So you're asking what are the ways that we can do to improve the survival of patients, for example, treated with liver resection or liver or transplantation, right? Yeah. I think the most important thing that can prolong the survival is the use of adjuvant therapy. So for example, in most other cancers, breast or colorectal, for example, or even lung, after surgery, there is systemic therapy in order to prevent recurrence. Unfortunately, in HCC, today there is no proven systemic therapy that can prevent recurrence. In other words, HCC is one of the few unfortunate cancers, it's a very common cancer, that has got no proven adjuvant therapy. But currently, a number of companies are running clinical trials to try to use systemic therapy, especially immunotherapy, as adjuvant therapy in such patients. And I think these trials are going to be matured very soon. And in the next few years, we would expect that some of these trials will be positive, and then patients after surgical resection or even liver transplantation can receive adjuvant therapy so that their survival becomes significantly longer. I think increasingly we are going to see systemic treatment moving from advanced HCC to intermediate HCC, and then maybe even to early HCC. So I will take the three groups of HCC differently. So for early HCC, the standard of care will still remain liver resection or transplantation because this gives huge survival advantage. But I see that in the near future, after surgical resection or liver transplantation, we will be able to use adjuvant therapy, adjuvant systemic therapy to improve the survival of these patients even more. For patients in the intermediate group, today the standard of care treatment is local regional therapy, for example, TACE, Y90, and so on. And here we are seeing a number of clinical trials running where systemic therapy is added on top of local regional therapy. And I think these trials will be positive, and this may well become standard of care in the future. First, you treat with systemic therapy, with local regional therapy, followed by systemic therapy. And eventually, the systemic therapy may be good enough to be standalone so that you can treat patients with systemic therapy upfront. But I see that as many years further down the road than immediately. For advanced HCC, I think the efficacy of systemic therapy will increase, will progressively increase and be even better as we understand the biology of HCC better. So I think in many instances, going forward, it'll be combination therapies rather than monotherapies. We expect to see immunotherapy combined with non-immunotherapy in improving the outcomes of the patients with advanced HCC. So this is how I see systemic therapy coming into play in treatment of HCC.